This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Temptation. Want to know what my biggest phobia is? When not to wash a wound? And what toxicology problem the World Health Organization calls a neglected tropical disease, killing more than 100,000 people per year? Listen to find out. Today's episode starts in the emergency department in the American Southwest. You're trying to decide whether to eat a glazed or a chocolate donut when you hear a loud commotion from the ambulance bay. It's not an ambulance, but rather someone in a car shouting for help. Often this means a gunshot wound, but not today. The driver is shouting and pointing at the man slumped in the passenger seat with his head lolling back. You grab a stretcher and wheel it outside. The rest of your team pulls the patient from the car and moves him into your critical care room. The man is awake and holding his neck. He's not talking, and he makes gurgling sounds with every breath. You move his hands away from his neck. The right side is extremely swollen, reddish purple in color. There are 2 side-by-side puncture wounds in the center of the affected area. Question number 1. This wound is consistent with which injury? A, a snake bite. B, a scorpion envenomation. C, bee stings. Or D, a stonefish envenomation. The answer is A. 2 puncture wounds next to each other is the classic pattern of a snake bite. The other exposures result in 1 puncture wound, and even if the patient sustained multiple stings, the punctures wouldn't be lined up exactly parallel. The driver of the car, the man's brother, confirms the patient was bitten by a snake 15 minutes prior to arrival. The men immediately jumped into the truck and raced to the hospital. The patient's condition declined precipitously en route. The nurses hooked the patient up to the cardiac monitor and start IVs in each arm. The swelling is progressing right in front of your eyes. I hope you're ready. Today's questions are rapid fire because this is a rapid fire type of case, so buckle up. Question number 2. What about this case is most concerning? A, determining what species of snake bit him. B, the risk of bleeding from the bite. C, the location of the bite. The answer in this case is C. The other aspects are certainly important, but the location of the bite makes it an absolute life-threatening emergency. I hear some of you arguing we need to know the species of snake. Of course, it would be helpful. The truth is we don't always know in the emergency department, and we have to manage the patient, as usual, without all the necessary information. What we do know for a definite fact, snake bites to the head and neck are extremely dangerous and associated with high mortality rates. Why? The patient makes a few more gurgling noises and grabs his neck again. That's the sound of someone about to lose their airway, and we need to act immediately. The problem is his neck is not only swelling on the outside, but thanks to the injection of venom from the snake's fangs, it's also swelling on the inside. Like a throat swelling shut from anaphylactic shock, though of course it's a totally different mechanism. He needs a breathing tube now, superstat, before the airway swells shut and you can't pass the tube at all. This kind of airway is every emergency medicine physician's worst nightmare. You use the laryngoscope to look down the back of his throat, attempting to visualize the vocal cords. Everything is red and pink and swollen, and none of the anatomy looks the way it's supposed to. It's hard to keep a grip on the handle because your palms are sweaty. After several heart-pounding seconds, you finally find the barely visible white vocal cords and squeeze the tube through the narrow opening. What if the patient had arrived a few minutes later, if his airway was already swollen shut? In that case, you'd have to do an emergency cricothyroidotomy, essentially cutting a hole in his neck to put a tube directly into the trachea. But even this would be difficult thanks to the swelling obscuring your landmarks on the outside. We've secured the airway. I need a deep breath just thinking about this, even though it's a fictional case. Question number 3. What's the next step? A, apply a tourniquet. B, administer antivenom. C, apply suction to the wound to suck out the venom. D, a fasciotomy. In other words, call surgery to place incisions in the patient's neck to relieve the pressure. The answer is B, antivenom. More on the other answers in a bit. We've secured his airway, but he could still die. Only 5 people a year die from snake bites in the US, and we really don't want him to be one of the statistics, so he needs antivenom. Did I hear you ask how to give it when we don't know what kind of snake bit him? Question number 4. What should we do now? A, ask the brother to describe the snake and see what local snakes fit the description. B, forget the description, ask the brother to go and try to find the snake and bring it back for identification. or C, treat empirically. So let's first talk about snakes, then antivenom, then back to the answer to this question. About 25% of snakes are venomous, and hold here so I can clarify a toxicology pet peeve. The difference between poisonous and venomous. Poisons have to be ingested, inhaled, or absorbed. Venom is injected by the wildlife. In other words, if you bite the animal and get sick, it's poisonous. If it bites you and you get sick, it's venomous. We're going to focus on North American snakes to prevent this episode from becoming several days long. There are 4 families of venomous snakes, of which 2 live in the U.S. We have elapids, usually coral snakes, and the venom of these snakes is neurotoxic, causing weakness, paralysis, respiratory failure, and death. The bites are actually minimal because there's no significant tissue damage, and the onset of toxicity can be delayed for up to 12 hours. Also, apparently when biting, coral snakes latch on and are difficult to get off. So this is another clue which I personally hope never to see. Our patient obviously wasn't bitten by a coral snake. The second family of venomous snakes in the U.S., the cause of most snake bites, is the Viperidae family, specifically pit vipers, crotalids in Latin, like copperheads and rattlesnakes. Venom of all snakes contains literally hundreds of compounds, and the composition of the venom varies with the species of the snake, the location where the snake lives, its age, and its diet. Crotalid venom effects are hemotoxic, cytotoxic, and myotoxic, meaning toxic to blood, cells, and muscles, just to name the major effects. The rapid swelling of our patient's neck is thanks to tissue damage, so this is definitely a crotalid bite. We now know what kind of snake, what kind of antivenom. In this episode, we get to discuss one of my favorite topics, new antidotes. For many years, we used Crofab for North American crotalid bites. It's a sheep-derived antivenom made from the pooled venom of 4 different kinds of North American crotalids. It's an FAB antibody fragment, like another antidote, Digibind. It works well except for one area. It doesn't treat the hemotoxic effects of the venom effectively. So now we have a new antivenom, brand name Anavip. It was designed to treat the hematologic effects of venom more effectively. It's also an antibody fragment from horses against the pooled venom of 2 North American crotalids. Fortunately, in the U.S., we don't need to determine what exact snake bit him because both antidotes work against all North American crotalids. So, answering question number 4, we don't need the brother to describe or bring us the snake. It is not, I repeat, it is not recommended that someone try to catch the snake. Bystanders have been envenomated attempting to do so. Question number 5, true or false? You can be envenomated by a dead snake. A, true, B, false. The answer is A, true. Sometimes patients bring the head of a dead snake to the emergency department. Whatever you do, don't touch it. The fangs have a spring mechanism that works even after they're dead and decapitated. Touching the fangs causes a reflex venom release. In fact, someone was even envenomated by a freeze-dried rattlesnake sold as a souvenir at a national park. For some reason, they were using the snake head as a tie tack when the fangs envenomated them. We do need to determine who needs antivenom because, believe it or not, it's not everyone. About 25% of bites are what we call dry bites. The snake doesn't inject any venom. The bite is to scare you to go away and leave them alone rather than kill you. So how can you tell if it's a dry bite? Well, really, observation. If the bite swells up, the patient's been envenomated. But if you watch the bite for around 6 to 12 hours and it doesn't change, then it's a dry bite and the patient won't require antivenom. So the answer to question 4 is C, empiric treatment with antivenom. Our patient clearly meets the criteria. You order 10 vials, the standard dose of Anavip, over an hour. He's admitted to the ICU. As I mentioned, 5 people die a year in the U.S. from snake bites versus about 130,000 per year worldwide. The World Health Organization classifies snake bites as a neglected tropical disease. What accounts for this staggering mortality difference? Well, first is the prevalence of the snakes. In areas like India, for example, there are tons of venomous snakes, and they live in very close proximity to humans, unlike the U.S. Southwest, where the snakes can generally avoid human interaction. The second is medical care and access to antivenom. And the third is the safety of the antivenom itself. Not all antivenoms are as safe as Crofab and Anavip. Venom is made by milking snakes, injecting small amounts into animals like horses or sheep, and then obtaining antibodies from the exposed animal. Antibodies are Y-shaped, and the top part, the V shape, binds to the toxin. The lower part of the Y is strongly identified with the animal from which it came, and if that part is injected into humans, it causes a very strong immune response. Crofab and Antivip consist of the top part of the antibody only, reducing the unwanted immune response and subsequent allergic reactions to a pretty low level. But this isn't always the case with antivenoms used outside the US. Most acute, in other words, immediate allergic reactions are mild, but anaphylaxis can occur. In a Sri Lankan study of patients treated with Indian manufactured antivenom, 43% had severe acute reactions to the antivenom itself, including altered mental status and low blood pressure. You can give test doses to see how patients react, and you can administer antivenoms at slower rates to avoid allergic reactions, but ultimately, you're still dealing with an envenomation, so it's a bit of an issue. Serum sickness, which is essentially a delayed reaction, occurs about 5 to 10 days after exposure to any antivenom. It's really unclear how often it happens because estimates are all over the map. So, outside of location and access to care, elements increasing the risk of death include bites to the head and neck. The venom effects threaten the airway as well as large important blood vessels like your carotid artery and jugular vein. In fact, intravascular injection of venom anywhere increases the risk of the snake bite because the venom rapidly enters the circulation. All patients with crotolid bites are at risk for bleeding, and some patients have severe life-threatening bleeding like an intracranial hemorrhage or a large gastrointestinal bleed. Patients with severe envenomation, like our patient, may require additional doses of Antivip. So, while waiting to see if he needs more, let's discuss the incredible amount of lore and misinformation associated with snake bites and their treatment. What should you do if you're bitten by a snake? Well, I'd probably scream bloody murder than expire on the spot from a heart attack, but I don't recommend this approach, especially if you're in the US. Take a deep breath first, because in the US, you're more likely to die from a bee sting than a snake bite. What else not to do after a snake bite could be its own episode. We don't use tourniquets. They can actually increase tissue damage and they don't improve outcomes. Of course, you couldn't put a tourniquet on his neck anyway. What about a pressure dressing? Well, recommendations are variable, but in the US, they are not recommended. Should you cut the bite open and suck out the venom? Absolutely not. You won't reduce the risk of envenomation, and you will introduce a lot of bacteria from your own mouth, increasing the risk of infection. Don't waste your money on suction devices. They don't work either. And please, don't try to zap out the venom. The victim does not need to be electrocuted immediately following. Since the dawn of time, pretty much, it appears treatment for snake bites was often worse than the bite itself. Ancient Egyptians cut them open to let the evil spirits out. Romans amputated the body part. In medieval times, a physician wrote the severed head of the snake should be applied to the wound as a plaster. And American cowboys treated bites with a hot branding iron. Washing the wound with soap and water to prevent infection is recommended, except in Australia, interestingly enough. Why? There they use snake venom detection kits to help determine what type of venom the patient was exposed to, as well as the presence or absence of venom. The tests aren't perfect, but can be useful in treatment decisions, so cleaning the wound isn't recommended until after testing. I promise to tell you my biggest phobia. I share it with Indiana Jones. You guessed it, snakes. Before I started my toxicology fellowship, I imagined hikers and gardeners attacked by vicious snakes with fangs dripping in venom. So imagine my surprise when I learned that 50% of bites occur on the upper extremities, meaning it's not the misstep of an innocent hiker, but rather somebody trying to grab the snake. Legitimate bites is the term given to accidental bites, and illegitimate describes essentially provoked bites. This terminology is a little strange, but anyway, in the US, 75% of illegitimate bites occur in men. Alcohol is often involved. One well-known toxicologist said he'd seen one single illegitimate bite in a woman saying, quote, "Women are far too intelligent to go messing around," end quote. So what happens if you're in the US and you're bitten by an exotic snake? A classic story is as follows. Doc, I was sitting in Central Park when I got bitten by... Insert here the name of a rare and exotic snake species definitely not native to Central Park or Manhattan or even the US. First of all, foreign snakes are not lurking under the bushes and benches of Central Park, and even if they were, how did this person know the exact species of snake it's always a he, was bitten by? Many hospitals in the US don't have Crofab or Antivip, and they certainly don't have other antivenoms, most of which aren't approved for use in the US anyway. If you're working in an ER and this happens, call your local poison center immediately. Different poison centers have different protocols. Often they'll reach out to places that might keep exotic antivenoms, for example, the zoo. Many zoos stock antivenom for the creatures in their care, and often they will share with a nearby hospital. Finding the right antivenom, though, is definitely no guarantee. When the police investigate these incidents rather than a snake loose in the park, they usually find the patient's garage filled with illegally imported snakes. You've probably heard about or seen on TV religious snake handlers. Frequently, the pastors die from snake bites. I came across something even more bizarre during my research, so-called snake venom addiction. I'm not sure this meets the criteria for a true addiction as a psychiatrist would define it. Nevertheless, it's as hard to believe as it sounds. Patients, particularly in India where the case reports originate, go to dens or parties and raves where they are intentionally bitten by snakes. I have no idea what kinds of snakes are used or if there's actually any venom involved, but the snakes are wrapped on the head, forcing them to bite, starting on a person's pinky fingers or toes, progressing to the ears, lips, and even the tongue. Patients report feeling calm and relaxed afterwards. I really don't have any further details on this, though I am dying to know more, and if you know something about it, please let me know. While on this topic, let me mention there's no convincing evidence of anyone developing immunity to snake venom. In fact, with re-exposure, the risk might increase due to the risk of anaphylaxis. There's a long history of veneration of snakes, not just in India, but around the world. Snakes are one of the oldest and most widespread symbols found in Gilgamesh, the Bible, Aztec, Native American, Hindu, and Norse mythology, just to name a few. They represent everything from evil, the underworld, and death to fertility, rebirth, and eternity. The staff of Asclepius, with a snake wrapped around it, is the symbol of medicine even in modern times. Derivatives of snake venom are used in modern medicine, in the blood pressure medicines captopril and enalapril, and blood-thinning medicines like tirofiban. Let's check on our patient to see if we've achieved control with the antidote. What does this mean? Essentially, rapid progression of the swelling has stopped. There's no evidence of serious bleeding or other major venom effects. Our patient is still having swelling. It's now extending down his arm, and the ICU has consulted surgery to see about a fasciotomy. A fasciotomy is essentially slicing open an area to reduce the pressure from swelling. A good idea? Well, crotolid wounds look awful and surgeons love to operate. Nevertheless, the answer is almost always no. The best treatment for an elevated compartment pressure is more antivenom, so let's order another dose. As I've said, you're more likely to die from a bee sting in the US than a snake bite. Not so worldwide. It's estimated 5 million people a year are bitten, and about 130,000 die. The sequelae for survivors can be severe. Many are left disabled or disfigured. Blindness can occur after ocular exposure. Renal failure is possible, and many patients suffer from PTSD and depression afterwards. 2 days later, our patient, amazingly, is awake and extubated. He tells you what happened during the camping trip with his brother. They found a rattlesnake under a rock, and thanks to a few too many beers, he decided to catch the snake for a closer look. He did catch it and held it up when it struck him in the neck. His cardiac monitor shows his heart rate is 120 beats per minute and his blood pressure is high at 180/90. He looks pretty shaky. Is this a side effect of the snake bite? Is he having an allergic reaction to Anavit? You ask him to stick out his tongue, noting fasciculations along the sides. Nope. This is alcohol withdrawal, another known side effect of snake bites. You leave the room and tell your ICU colleagues so they can start treatment. No word on the snake status, but the patient recovers without sequelae, declining help for his alcohol use disorder and looking forward to future camping trips. This is a fictional case, as are all our cases to protect the innocent, but it is based on real poisonings. The last question in today's podcast: what animal is both venomous and poisonous? A. Scorpionfish, B. The blue-ringed octopus, C. Gila monsters, or D. The keelback snake? Follow the Twitter and Instagram feeds both at PickPoison1 and you'll see the answer when I post it. Remember, never try anything on this podcast at home or anywhere else. Finally, thanks for your attention. I hope you enjoy listening as much as I enjoyed making the podcast. It helps if you subscribe, leave reviews, and/or tell your friends. All the episodes are available on our website, pickpoison.com, Apple, Spotify, or any location where podcasts are available. Transcripts are available on the website. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.
This podcast is a production of Unfiltered Studios. If you would like to know more about joining Unfiltered Studios, please visit our website at unfpod.com for more information.